the message around vaccination is really critical. And I appreciate that there's a lot of information out there, and we need to distill through this information. And hopefully I'll be able to give some background. I'm currently at work today, busy with the unplanned recruitment for an important vaccination study, where we're comparing the original Oxford vaccine to a newer version, which is tailored to deal with the variants, but we'll talk a bit more about that. So apologies if the lighting is not so good. I just had to make some space where we could get this done. In terms of my background, if you can see, I've got, compared to the picture that's been put up, I think that's my before COVID picture, and this is my after COVID picture with the gray hair and the beard. So I think, COVID has taken a toll on everyone. As a general practitioner, my background or my interest is in sports medicine, is in clinical research, where I completed a master's in clinical trials through the University of Sydney. I run a research center based in Soweto, and I've got about 18 years of experience in clinical trials. So hopefully that has taught me some important lessons, and I've learned along the way, and I'm hoping to share some of that with you guys today. With that, I'm going to share my screen just to say welcome to everyone, wherever you are. I think, as Charles said, it could be good morning, good afternoon, good evening. Just to say welcome, thank you for taking the time to log in and to view this presentation. Hopefully it'll be of value. Again, as I said, this is, what the sort of brief is. We're talking COVID-19 vaccination, what you need to know. As I said, that's probably my before picture, before COVID. So let's get straight into it. Everyone by now is probably familiar with COVID-19, which is the disease that SARS-CoV-2 virus causes. And SARS-CoV-2 is a newly discovered virus. While it's newly discovered, it is part of a family of viruses called coronaviruses, which have been infecting humans for a long time. Obviously, this is a special variant of that coronavirus, a new class of virus discovered. First cases of human infection were identified in Wuhan in China in late December 2019. And in terms of the African continent, the first case was actually discovered or diagnosed in Egypt on the 14th of February 2020. So marking the beginning of Valentine's Day in not a good way. By the end of March, so that was February, by the end of March, 9 additional countries listed there were reporting over 40 cases in total. The World Health Organization, WHO, declared this outbreak a pandemic on the 11th of March, 2020. So that's just a bit of historical timeline, including Africa. In terms of the global statistics, and this is again is from the WHO, if we look at 27th of August, it just shows you the entire globe, and obviously different shades of blue represent different counts in terms of diagnosis of COVID-19. And as you can see, there's virtually no part of the world that is spared. This is truly a global pandemic. Given how we are a global village now in terms of people movement, travel, and so too do viruses now travel easier. And obviously that's one of the thinking behind lockdowns and how people control their borders, trying to control access of not only people, but the viruses that may accompany them. If we look at exact numbers as of that date, we're looking at 215 almost million cases globally, and that's confirmed cases. Remember, so those are people who've had a positive test. Not necessarily everyone who's had the virus, because not everyone has access to testing or healthcare facilities. So we'll talk a bit more about the numbers. In terms of deaths, we're approaching 4.5 million deaths. On the plus side or on the positive, we're looking at close to 5 billion doses of COVID vaccines being administered. And I think that's an important number which we'll touch on later. I just wanted to cover, we hear these numbers of deaths and we say, 4.49, say 4.5 million people have died. Sometimes we don't place those numbers in context and we don't sort of internalize it. And I'd like us to just look at, these are deaths caused by wars. So in the history of mankind, the deaths that have been caused over time. In red is the average numbers of deaths per year and versus the total death. Now let's bear in mind that COVID has been around with us for probably a year and a half, maybe even if we count 2 years. So if we divide that number, we're looking at about 2.25 annual deaths. So that places it right between the Bangladesh Liberation War and the Taiping Rebellion. So that's number 4 in the history of events causing annual deaths. Really, that is staggering, as I said, for a disease of this nature to outstrip wars in terms of a death toll is significant. So that's just to contextualize it globally. If we look at specifically African data, we're looking at approximately 7.66 million deaths. And again, these are confirmed cases, so not every case. And if we take it further, the number of, the previous slide was number of cases. This is the number of deaths from Africa. Again, confirmed cases, 191,000. And an interesting stat that I found, this was a study done, funded by the USAID and other organizations, where they looked at the number of deaths over a period of 20 years in Africa caused by natural disasters. So drought, temperatures, floods, storms. Now this is the total, 46,000 deaths caused by these natural disasters over a period of 20 years. If we look at Africa, we are looking at 191,000 within 2 years. Again, just emphasizing and placing into context the massive impact that COVID-19 has had on everyone across the world and in Africa. This is a leaderboard, and unfortunately it's a leaderboard for the African region, the Special Olympics African region. I've tried to include the countries that are represented here. And this is a leaderboard. Unfortunately, in sports, we like to be at the top of the leaderboard. This leaderboard, you don't want to be on the top. This is the total number of cases, and it's adjusted so that we can compare countries per million people. So it means these are the number of cases that you have had per million people in that country. So it just gives us a way to compare countries. And you can see leading this leaderboard is Seychelles with almost 200,000 people testing positive per million people in their population. So that means 1 in 5 people in Seychelles tested positive. And we go down the list, and South Africa is here with 45,000. So this is just to show that the numbers are significant and real for Africa. In terms of deaths, again, per million people, which I think is the best way to compare. Unfortunately, my country, South Africa, is leading that one, and we are close to 1,350 odd people dying per million people within the country. And obviously the number goes lower, the lower down you go. So these were taken on August 27th. Obviously there's daily counts and data is being updated. I would encourage everyone to visit this website, Our World in Data. It's funded by it's detailed by Johns Hopkins University, and they really have the ability to dissect data, and you can look specifically for your country, for trends, for different options of data. So that's important. Then just to show everyone in South Africa, again, on the 27th of August, our Department of Health puts out this infographic daily. So it updates daily. It gives us a breakdown of each of the provinces within the country, with each showing deaths, confirmed cases, recoveries, and then overall counts. So you can see in South Africa on that day, we had up to 81,000 in total. From the beginning, we had 12,000 new cases, which is not good. We're still in our third wave, which is prolonging. We also see the recovery rate. So 91% of people who were infected have recovered, with 9% not yet recovered, not necessarily to say they've passed on, but not yet completely recovered. The total number of deaths per day. And recently, since we started our vaccine rollout, they've given us a count of the vaccines administered, which is close to 12 million. And it's increasing by approximately 1 million new doses per week. So this I like very much from a local perspective, and I would encourage people to search for theirs within their countries, create them. It's valuable tools to look at comparisons and trends. I mentioned earlier that the numbers, are there, and we've got, counts, but are they really accurate? In terms of COVID-19, this is an interesting analysis which was performed about August. They looked at they looked at a few countries, but specifically Africa. We looked at South Africa and Egypt. And this is a period this is over a year in South Africa, from January to February. This peak represents our first wave. This is our second wave. And what they found is if they looked at historical data, meaning over the last 5 to 10 years, how many deaths on average per week should we experience over these months, over this period of 12 months? And that's the dotted or the dashed black line. So that is what we would expect to see based on historical perspectives. If you look at the red, so that's a peak, our first peak and our second peak. The first peak shows the excess number of deaths that were directly caused by COVID. So these were COVID positive people diagnosed and on the death certificate listed as COVID-19. So that's confirmed or official COVID deaths. But if you look at the blue mountain, you can see that these are people who died during that peak, but were not classified as COVID-19. They were classified as other or unclassified, never had a COVID test, died in a rural area where we couldn't get those type of details. So I think if you just look at it, this is per week. I mean, we're talking excess of 5,000 per week deaths that possibly were due to COVID, but were never classified as such. And exactly the same scenario in Egypt. So what does this say? This says to us that we are underestimating the number of COVID deaths. So even though I've painted a grim picture where we've looked at world wars and we've looked at natural disasters in Africa, and we're still ranking high in terms of COVID deaths, that's probably not the whole story. It's probably worse than we think. I mean, what they say, it's the tip of the iceberg. This was an interesting study published by the European Respiratory Society in February. What they did was they looked at 22 different countries. Again, they looked at the 5-year mortality, and European countries, there's Oceania, there's Africa, United States. So they tried to get a global analysis. And what they found was an excess of 700,000 deaths during these peaks that were not explained and should probably be COVID. So they were not classified as COVID, but there's an increase according to the historical numbers. And overall, they're saying we're underestimating COVID-19 deaths by 35%. Now, as I said, place that in context of the numbers I gave you before, this makes it even worse. And really, 35% obviously varies from country to country. There are some countries who are very pedantic and pay attention to every death, and they might not have any increase. And then again, there's countries that the tracking systems and the health systems are not as well established, and we're missing more. But this is average. So globally, we can add 35% to all these numbers, and there's probably a more truer reflection. Now that I've painted, the worst possible picture, I think, I just wanted everyone to understand the seriousness, firstly, of this disease, because there are, as mentioned, there's a lot of false information going out. There's a lot of COVID denialists, which I still don't understand. But really, this is a significant problem, and dealing with anything in life starts with first recognizing that there is a problem. So COVID-19, how is it transmitted? I'm going to go through some basics. And if you are infected with COVID-19, or if you're not, what we do is when we talk, when we exhale, breathe in and out, when we cough or when we sneeze, we shoot out from our mouth and our nose droplets that contain fluid and that might contain a virus if we're infected. These droplets could be small or big, right, depending on the size. And the smaller ones, which we call aerosols, actually float. Some will stay in the air for longer than the others because they're slightly lighter or heavier. And the heavier ones will fall directly in and around the vicinity where you're talking, coughing, or sneezing. So what happens in terms of coronavirus and COVID-19 is you've got a person who's infected with coronavirus. He coughs, sneezes, talks in and around people. And what happens then is that these droplets either go into the air or fall on objects within a radius. We're estimating it between 1 to 2 meters. And in the air, obviously people nearby might then inhale those droplets, which could result in infection in themselves. They've been exposed. Or if it falls on objects, if we don't wash the objects or sanitize them, we pick up a phone that's a communal phone, door handles in public spaces, vehicles, taxis, etc. We touch that, and you'll be surprised how many times a day your hands actually touch your nose and mouth, and therefore we carry the virus from the object actually into our system. So that's just a bit of background there so that we understand when we talk about limiting and mitigating our risks. I've got a nice slide here which shows from Special Olympics that they did an analysis in New York where they showed a 5 times higher transmission of COVID-19 and a 5 times higher death rate amongst people with intellectual and developmental disabilities. And, you know, if you research this, they are at higher risk because of individual factors as well as societal factors. And the individual factors, I mean, could be related to limited mobility, could be related to difficulty understanding information, practicing preventative measures, people who have existing health conditions which go together with the other disabilities. So there's a lot of individual factors, but I think in society nowadays, we have many more societal or community factors or barriers to people accessing public healthcare information, basic hygiene measures. I think this is where we can make significant impacts in minimizing our risks and preventing COVID from being spread. If you are unfortunate enough and you do get COVID, get infected with the virus, these are some of the symptoms that you could expect. You might not get all, you might get some of them. And again, there are some people who don't have any symptoms yet they're infected. They call asymptomatic positives. And what are the basic symptoms? Headaches, cough, sore throat. So you look at this and you say, this is a bit of a flu, maybe a bit of a tummy bug. The one feature of COVID virus that sort of we thought would identify itself clinically was loss of taste and smell. So that is something that we pay attention to when we're examining or taking a history from our patients. But if you look at these symptoms, really it's non-specific. You know, it's very easy to ignore and not get tested. So if you have any symptoms, you think it's a flu-like illness, do not ignore it, get tested, because if you are positive with COVID, then you need to take certain measures. Remember, COVID is spread close. Person-to-person contact is one of the main reasons for spread. As I discussed with the droplets, your symptoms after exposure may take 2 to 14 days, and some people might not even get symptoms. And remember, we need to do a test as early as possible so we identify and limit the spread of disease. If you get diagnosed with COVID and it's a mild disease, in 90% of people, as I showed earlier, they recover. Firstly, we need to isolate that person. So we need to make the diagnosis and then isolate. And isolate, I mean, it's a very harsh word. I think it makes people scared. It sounds like it's punitive, like we're punishing someone. But really, I think we need to actually find better wording for this. But what we basically want to do is keep this person separated from other people who may be at risk. So if they have their own room and they can have their own space, which is well ventilated, we need to look after them. Secondly, people interacting with the person who's infected should definitely wear a mask, definitely hand sanitize, frequently clean areas, try and use separate dishes and cups and you know, towels, etc., so that there's limited exposure to the people caring. Ideally, the person you choose to look after the person who's sick, you would like to find a person, nominate one person who's healthy, strong, and preferably who's vaccinated, so that they are at low risk of contracting the disease, and that person can then tend to the needs of that person who's sick. And that's important. We don't isolate and leave them and not care about them. At the end of the day, we need to monitor them. There's 10% or up to 10% of people who will get worse. 90%, 9 out of 10 people will recover, but we need to keep an eye in terms of temperature, how they're breathing, etc. Make sure that they're resting, make sure that they take enough fluids so that they're hydrated. And we need to know when that person gets worse. So danger signs, are they having difficulty breathing, confusion, chest pain, any sudden change or any change in the person that you feel, it warrants attention, you'd rather seek help early. These people who do deteriorate normally deteriorate after day 7. The first 7 days are usually a mild flu. And unfortunately, if you're going to deteriorate between 7 to 14 days, you take a turn for the worse, and that's when you require, medical intervention. So I would definitely keep an eye on them. As I said, I don't like this wording. It's a very harsh nomenclature for something that we use in medicine. But just to understand the difference between quarantining and isolation. So a quarantine is when we keep someone, you were in close contact with someone who had COVID-19. So therefore, you need to now be quarantined until you either show that you picked up the infection or not. And that period is 14 days, because as I said, it can take up to 14 days for you from being exposed to having symptoms. So we have to keep an eye on you, and you have to avoid exposing other people in that time if you did pick it up. But if by 14 days you didn't get any symptoms, that means you're fine, and then you can come out of quarantining. Whereas isolation is someone who's already positive. They've tested positive, whether they have symptoms or not, they've tested positive, and they need to isolate for at least 10 days from the onset of their symptoms. So I think just important to understand the difference. Sometimes people use it interchangeably, but it isn't. So how do we minimize the risk? And as I said, knowing how the virus spreads is very important, because then you know how to combat it. And I heard a saying from one of the microbiologists who said that the virus does not have legs, meaning the virus cannot move without a human host. So it's basically us that take it from point A to point B. The virus can't do it on its own. So if we restrict certain things, we can then limit the virus. So firstly, frequent hand washing, which makes sense. Soap and water, if you can. If you have a sanitizer with at least 60% alcohol, by all means, but frequently. And I think in South Africa, I'm very happy that this has become the norm. You go into a shopping center, before you enter the shopping center, they have sanitizers available. You're forced to do it. Before entering any shop, there's someone from the shop who, as a staff, would come to you and sanitize your hand. Wearing cloth mask is compulsory in South Africa, and I would hope it's globally that if people are buying into this. There was a lot of resistance to this, saying, it affects your oxygenation and all of that nonsense. As doctors who work in theater where they wear a surgical mask for operations that last 10 hours, and anesthetists do it daily, and it does not affect your oxygenation at all. So that's a complete misnomer. Obviously, coughing or sneezing into an elbow to limit the amount of droplets. So the droplets are caught by the tissue or by the handkerchief that you're using. Social distancing, because we think that the virus can only spread between 1 to 2 meters in the air. And then again, as we said, if you feel sick, stay at home, try avoiding touching your face very often, especially if you have a mask on, and clean and disinfect. Now, all of these are the universal sort of precautions we can take. But I think the focus for today, and what I'd really like to focus on, is vaccination as an important step in prevention. So this should go hand in hand with the universal precautions. Let's just take a quick walk down the history of vaccination. And on the right, you'll just see, the different timelines of different vaccines, of when they were introduced. And as you can see, we have many vaccines, not as many as we'd probably like, but we do have a significant amount of vaccines for very important diseases. And if we look at this history, key dates, the first vaccine was introduced around about 1796 by Edward Jenner. However, predating him in the 16th century, there's writing from scientists in China about preventative inoculations, which is what this is. And then you can see that the first virus was sort of isolated, multiple vaccines, combination vaccines, different timelines. The first vaccine against the flu was 1944. So this is just a history. Do vaccines save lives? Do they work? And this is, unfortunately, a lot of people's focus is, as anti-vaxxers, etc., they like to spread different information about whether vaccines work, and secondly, whether they're safe. So let's go through a bit of that. I think, it's an unequivocal yes from me. Do vaccines save lives? Yes. So let's look at this analysis again. It's looking from 1990 until 2017. And the colorful part of this bar graph shows the number of deaths from these vaccine preventable diseases, right? So if we look at 1990, we had 5.5 million deaths of children. So these are children younger than 5. 5.5 million deaths. And vaccinations obviously started occurring during this time for these diseases until 2017, where we now have 1.8 million deaths. So almost a 60 to 70% reduction in deaths, not just hospitalizations or feeling well or infections, deaths from those exact diseases. Really, this is convincing evidence to anyone who would like to find the information and follow logic. In the US alone, they did an analysis with these diseases and the vaccinations that were introduced. They didn't put a timeline because the vaccines were introduced at different time periods. So it's basically pre-vaccine in the red. And once we managed to introduce vaccine, this was now done in 2007, I think, that they did the analysis. So after all the interventions over the years. And we can see the reduction from 100% reduction in diphtheria, 99% in, 90% for Haemophilus influenza, hepatitis A and B, 80%, 99%. I mean, if you look at these numbers, really, this would be an examination report for your child or anyone that you'd be very happy with. This is fantastic. Yeah, so the evidence is clearly there. Vaccinations work and they save lives. If we look specifically at COVID-19 vaccine development, this was taken about a month ago from the WHO. 184 vaccines are in what we call preclinical stages. So if I just explain research, preclinical is before we start testing it in humans. So preclinical would include laboratory experiments, firstly, as well as on animals. And they choose animals that have similar sort of organ structure for the disease that we're studying. So here they would look at immune systems and they would choose animals that have similar immune systems, and that's where we would test it. And if it has a good safety profile and it seems to work under these conditions, then we go to first in human being studies in healthy young people, adults, right? And there's 37 in phase 1. After we say, right, it's still safe, we're always evaluating safety. Safety is the #1 priority in any development of any vaccine or medicine. That is the #1 flag. If there's any one flag, a red flag saying someone died after taking this vaccine, that vaccine would really pause in terms of the development, probably never reach further than that. So really, safety is the #1 priority. Then we go to phase 2, where we test it in broader groups of people, and then the large phase 3 studies, which are like 30,000, tens of thousands of people, where we look at, again, safety and exactly who it works better in, what medication can it be taken with, which people can and which people can't take it. Currently, there's about 20 different vaccines being offered, and some continuing to be monitored. So that just gives you a bit of a landscape. I want to spend a bit of time on this slide because I think this is where a lot of people sort of ask questions, how do the vaccines work, etc. So I just want to spend a bit of time here. Now, there are basically 4 different types of vaccines, right? Forget who they are first. Let's start at the bottom. At the bottom, you've got this green, I don't know what shapes these are, but we can call them whatever we want shape, but they're antibodies. So these are the antibodies which are your defense system against any infection, right? So if you imagine your body to be a country, right? And you have an invading virus or an invading army from your neighboring country. So it decides to invade your country. What happens is that firstly, you have to pick up that you've been invaded. So you need to have some sort of intelligence systems or personnel who pick up, hang on, there's something happening. These people are here and they might be dangerous for us. So they pick it up. Then they report it to your military, and your government and your military then sort of create an army or mobilize an army to fight off those invaders. And it's exactly the same that happens in the human body. Basically, you have the virus that enters the body. This blue and white dot is your immune system. It picks up when there's an invading virus. Whatever it may be, in whatever shape or form, don't get confused there. You've got an invading virus, which your immune system picks up and then says, right, let's deploy a specific army to combat that. So it develops an army specifically for that virus, okay? So that's how your immune system works. So what the vaccines do is they introduce the virus in a way that's safe. So they take a virus and they introduce it to your immune system and says, guys, here's a picture of the enemy, okay? Here's the invader who's going to come in the future to try and invade your body. So you trick your body into thinking, hey, hang on, here's a foreign invader, let me prepare an army. So you have an army ready. So when the actual virus, the COVID-19 virus, decides to invade, you already have an army ready to defeat that virus. And that's why it prevents the disease from even taking hold. So I think it's very important. The vaccines trick your body into thinking you have COVID. Your body makes this army, and that army then is on standby. At the moment, for some studies, it says the vaccine antibodies last 9 months and counting. So your military is on standby in case the real enemy approaches, and that's why they work. Now, you can introduce the virus to the body in various ways, and that's where you get the different vaccines. So if we start on the right, the protein subunit, what you do there simplistically is you take the virus, put it into a blender, chop it up, take a few pieces that you think represent the virus and inject it. So you're injecting pieces of the COVID virus. Now here, for COVID, we've taken the spike protein, which is the most recognizable part to the body. So we've said this is the characteristic that the body will recognize as COVID, so we use that. So that's one way of introducing the virus to trigger the immune response. Another way is you take the entire COVID virus and in simplistic terms, again, you castrate it, or you basically make it impotent in that virus has been treated in a way that it cannot infect a cell and that it cannot replicate, it cannot grow in the body. So you sort of put a weakened virus, the entire virus, as opposed to a piece, into the body. Your immune system picks it up, produces the antibodies, which is the army. And remember, that does no harm. That does no harm. The third way is via the much talked about RNA or messenger RNA viruses, vaccines, the messenger RNA vaccines. And what they do is, instead of taking any piece of the virus, like this one, or the entire virus, they actually inject a code, which is in the RNA, that goes into your body and asks your own cells to make this protein, okay? So instead of taking the protein pieces and injecting it, we got a code that we inject. Your body produces, some of the cells will produce this, and therefore your immune system will see this spike protein and produce antibodies again, okay? So that's how that works. The viral vector, we take a piece of the protein of the COVID virus and we put it into another harmless virus, okay? So a virus that doesn't cause any disease in humans, and that goes in, and when that virus replicates, it produces the spike protein. And then your body sees it and produces the antibodies. So I think that's irrespective of how your body gets exposed to the virus, the ultimate aim is to expose it to your immune system for you to prepare this military, which need to be on standby. This is just an overview of some of the vaccines available and the types. So you've got Pfizer and Moderna, which are the RNA vaccines. The viral vector, which is the AstraZeneca, Johnson & Johnson in South Africa, those are the two we're using. You've got whole virus vaccines where it's inactivated, and here's the example. Sinovac is one of them. And then you've got the protein subunit Novavax, and these are the more traditional type of vaccines. But these are the ways vaccines are made. Obviously, you know, politics never leaves anything alone, and you've been hearing certain, you know, reports of vaccine nationalism, vaccine apartheid, they've even gone on to say. And the reason that's come about is because of the statistics. So if we look at this report, as of June 2021, only 1.7% of Africa have been vaccinated, whereas we represent 17% of the world's population. So 1/10 have been vaccinated. Whereas if we look at the traditional Western or European countries, you can see that even though Europe makes up 10%, 17% of them have got of the global vaccines have been distributed there. And the same with North America. 3 times as many vaccines have been administered as compared to the population. Okay, so this is where, I mean, our President Cyril Ramaphosa has spoken about, and you know, we need to get this right. We need equitable distribution of vaccines, because we are all not safe unless all of us are safe. That's the bottom line. Given the global village we're in, we all need to be vaccinated. We need to reach herd immunity as a planet and not as a country. I think that's very important. I decided to just show the vaccine inequality in terms of the countries that are involved here and compare it against some of the, as I said, more Western countries. So if we look as of August, slightly different dates, but in August, Seychelles had 145 doses administered per 100 people. So that means they were already doing their second doses, which is fantastic. Mauritius, 100 doses per 100 people, so they pretty much 1 dose per person. And those are the outliers, unfortunately, within the, you know, the Special Olympics region. From there, it drops drastically to 36 out of 100 people in Cape Verde, Zimbabwe 19, and the list goes down and down. Really, I mean, these numbers are not good. If we look at versus, as I said, Israel, which was very preemptive in terms of their vaccination program, where 150 per 100 people, the EU, United States, at least at 100 per 100 people. This brings me to COVAX and the initiative of the Access to COVID Tools, the ACT Accelerator, which is a partnership by many organizations, countries, governments, and what they're trying to do is increase global access and accelerate the development, testing, and access to therapeutics, diagnostics, health systems, and vaccines. And the COVAX is a specific finance service to fund the vaccine distribution and development, with the aim of getting 20%, you know, of the population of the participating countries vaccinated by vaccine doses. So it costs a lot of money, but these are some of the global initiatives. In terms of the COVID vaccines themselves, Scientia, potentia est, knowledge is power. And I hope each of you listening, watching, would go through this with an open mind, and let's look at vaccine efficacy for COVID versus the side effect profile. And each person has a decision to make at the end of it as to what they feel, whether the risk is higher or whether the benefit is higher. All right. So as I said, knowledge is power. How do we show that the vaccine is working, especially for COVID? I'm going to show you 2 information via graphics. The first is a timeline from, again, Johns Hopkins University, where they compared the weekly cases at the top in red, and you can clearly see peak 1, 2, and 3, which we're currently in. Below that, in white, is the weekly deaths. And again, you see 3 distinct peaks. And those peaks usually follow the peaks in infections. So you have a peak in infections and subsequently the deaths. And it's quite clearly shown. The third graphic in green shows the weekly number of COVID vaccines administered. And as you can see, South Africa were not dosing until March, April, May this year. And that's where we see the peak, which we're now in terms of dosing. So we don't see any changes in the weekly cases or deaths. Now I want to put that side by side with the United Kingdom. Again, you see the weekly cases with the first peak not as big, second peak and a third peak. Again, in terms of the weekly deaths, even though the weekly cases weren't significant, we had a significantly higher death rate. And you can see a clear peak, again, another peak of deaths that follow the weekly cases. However, the UK started vaccinating a lot earlier, towards the end of 2020. So in the middle of the second wave, they started and it was sustained. And as I said, they're close to 70% of the population completely vaccinated. The impact of that vaccination for COVID can be clearly seen above. You still can get diagnosed or weekly cases, but the benefit of the vaccination lies in flattening out the number of hospitalizations and deaths. So in July, where we're seeing the peak in weekly cases, you're seeing hardly a peak in terms of the weekly deaths. And that's clear evidence of the benefit. And we're comparing two countries, similar health structures, training, etc. So really clear evidence in that graphic. The second exhibit I'd like to put forward, again, is an analysis, but in a slightly different way. Here, we have the total daily new cases per million people. Again, per million, so we can compare countries. So the total number of confirmed positive tests, you can see Israel significantly higher at 900 per million people, United Kingdom at about 500 per million people, and South Africa. So South Africa has the lowest number of cases. UK has double, Israel triple at a point, which is the 27th of August. And if we put that next to the daily confirmed death cases per million. So we got cases positive on the left, deaths on the right. You would expect the country that has the highest number of positive cases to have the highest death rate. Yet, South Africa, with the lowest number of cases, has the highest death rate at 5.24 people dying per million. So, I mean, that's almost 4 times higher than the United Kingdom, even though the United Kingdom has more cases. So, if we look at the case fatality rate, you can see that South Africa's case fatality rate, which means number of people positive who are dying. So what percentage? South Africa is 2.66, Israel and United Kingdom much lower, all right? And the answer comes in the next slide, showing the number of people who've had at least 1 dose of the vaccine. You can see that for the United Kingdom and Israel, they're almost 70%. So 70% of their population have been vaccinated. So yes, while they are getting cases testing positive, their case fatality rate and their death rate is much lower than South Africa. This is just a summary of the 2 different vaccines, 3 of them, showing the efficacy. And this is taken from a published article. If we look at Pfizer, Moderna, and AstraZeneca in terms of symptomatic infection, so if you get the vaccine, does it stop you from getting any COVID infection with symptoms? And the answer is yes, to a degree. With 2 doses of Pfizer, 93% less chance of getting an infection testing positive with symptoms. If we look at Moderna with 2 doses, 89%. If we look at Chadox, which is the AstraZeneca one, 67%. Yes, the range is 38 to 82, so it means it could be as low as 40%, but it's still a 40% chance of reducing your chance of getting COVID with a symptom. But if we then move on to how does it prevent hospitalization or death? And I think this is where you'll see that with 2 doses of Pfizer, we're looking at 96% reduction in hospitalization or death. Moderna, 96%, right? So I think that's clear, again, evidence about the benefit and understanding, because you'll get a lot of people saying, someone took the vaccine and they still got COVID. And the same argument goes for influenza vaccine. So remember, yes, you may still get it. Your chances are lower of getting it. But if you do get it, the chances of complications and ending up in hospital on a ventilator or dying are significantly reduced. And that's where the benefit is. That was the data, sort of the initial data based on the original virus. Unfortunately, the virus responded. And in this complicated slide, which I'm not going to go through completely, I just want to explain, because there's a lot of focus on variants. And any virus will have variants, has tons of variants. The WHO looks at these variants, and the countries and the scientists, they study them. And only if a variant causes increased transmissibility, means it can spread easier, or it makes the person who gets infected with that variant more ill, or it evades the vaccine, means it reduces the efficacy of the vaccine. Only when a variant meets one of these or more than one of these criteria is it called a variant of concern. And that's the buzzword at the moment, VOC, variants of concern. At present, there are only 4 variants of concern in the world. The first is the Alpha, which was identified in the United Kingdom. Then we had the Beta, which was identified in South Africa. You've got Gamma from Brazil, and you've got Delta. Now, Delta, which was identified in India, definitely is more transmissible, and hence you will see, even in Africa, where we are gene sequencing in terms of the types of variances, you can see that Delta is the majority variant, and that's purely because it's so much more easily transmitted from person to person. So in South Africa, 96% of the tests who are positive are analyzed, and they found to be the Delta variant. So how does the vaccines that were developed against the original virus fare in terms of efficacy against the variants of concern? And it's summarized on the left, where the original virus, we had this type of protection, looked pretty good in terms of preventing the infection. And then we can see that with each vaccine, it might be, with each variant, it might be slightly decreased. I mean, the AstraZeneca, for example, I was involved in that study in South Africa, where we did not show benefit in terms of hospitalization with the Beta variant. That might be more deficiencies in terms of the data. Overall, I think that the benefit will remain. It's a question of proving it. I like this slide, even though it's a bit confusing. And the reason I like it is it compares hospitalization on the right. So forget the symptomatic infection, which you may have decreased efficacy against the variants, meaning you might still get it. I mean, if we look at in Israel, from about 90% with the Pfizer vaccine on the Alpha variant, with the Delta variant, that drops to about 60%. So yes, it still protects you, 60% chance of not getting it, okay? But if we look at hospital admissions, you can see that whether it's with the Alpha or the much more circulating Delta now, you can see that the lines are pretty much similar in that the efficacy to prevent hospitalization remains. In Israel, again, you're looking at 90-something to high 90s to maybe high 80s or 90 itself, okay? Some even improved in terms of AstraZeneca, the improvement in that it targeted the Delta better. So in terms of the circulating virus at present, you can see that there still remains benefit with all the vaccines in terms of hospital admission. And that's summarized again in this slide. At the top, you've got the original virus, you've got the Alpha, Beta, and Gamma, and the Delta. Let's ignore symptomatic infection, because if you get a mild infection, symptoms goes away, no one's going to be too stressed about that. But if you end up in hospital or die, obviously that's what we want to prevent. So if we look at hospitalizations with Pfizer, 96% original, 95, 95 against some of the variants. Look at Moderna, 96, 94 against Alpha. Look at Oxford against the variants, 85, 83, 88. So really significant benefit in terms of preventing hospitalization and death. And I wanted to illustrate this by numbers. This was posted 3 days back on the August 31st by the Houston Healthcare Group, which is 2 hospitals in the United States of America. And they wanted to visually represent real life data of people who have been vaccinated, not vaccinated, and who are then getting admitted. So in terms of the 129 people they have hospitalized with COVID, 14 of them in the white are vaccinated. The vast majority unvaccinated. If you move one step further, in hospital, 68 people are in the ICU. Of that 68 people, 3, again in the white, are vaccinated, but 65 were unvaccinated. And lastly, if you look at people on ventilators, not a single person who has been vaccinated was on a ventilator. All 34 on the ventilators were previously unvaccinated. And this graphically shows us the real life data and benefits of vaccination versus not. If you were vaccinated, you had a much lower chance of being in hospital, being in ICU, or being on a ventilator. And I mean, one of the headlines read that COVID, the pandemic, is fast becoming a pandemic of the unvaccinated, in that the vaccinated people will get it, they'll have mild symptoms, but not suffer this disastrous consequences. Again, another study to just illustrate the benefits of vaccine, where they looked at how the pandemic would have shaped in the United States. Obviously, it's through modeling, etc., with and without the vaccination. And they anticipated, and they showed in their study, that if the United States did not embark on its vaccination drive, there would have been 279,000 additional deaths and 1.25 million additional hospitalizations. So they predicted significant alleviation on the healthcare facility from the rollout of vaccinations. So that's the efficacy. Then we come to the safety. And I want to highlight that the safety data we have is significant. If we look at the total number of doses administered globally, on the August 26th, it was 5 billion. I want to put that in context, in that only 1.5 billion influenza or flu vaccines are produced per year, not dosed, because not everyone uses the vaccine. Some of it goes to waste, but that's the maximum in a year. So we've got a multiple of 5 billion here. The amount of data, safety data we have is enormous. This study in the United Kingdom, published on the left, showed 600,000 people who were either given Pfizer, 2 doses, or AstraZeneca, and they looked at 2 types of side effects. Systemic, which just means general, and they looked at local, which is where the injection were given. And these were the incidents, so how often these symptoms occurred. With the Pfizer vaccine, 22% and 33%. So say 2 to 3 out of 10 people who got the vaccine had systemic. So that means if we look on the left, headache, fatigue, chills, diarrhea, fever, all of that combined, nausea, arthralgia, body pains. And the local is a lot higher because remember, this vaccine is given by an injection. So it's a needle into your arm. So that has to cause a bit of pain, swelling, etc. So that's more common. Now remember, if we go back to how vaccines worked, we try and trick your body into believing it has COVID so that you can produce the army. So when we trick your body, and we do a good job of tricking your body into thinking it has an infection, your body reacts as though it has an infection. And therefore you look at these, and these are similar to the symptoms of a flu or COVID. So your body actually thinks, hey, hang on, I have an infection, I need to mobilize my army. And that's where these side effects come in. But we're looking at 2 to 3 people out of every 10. who have those type of reactions. That's the common ones to expect. And obviously the local at the injection site, pain, tenderness, swelling, redness, that's more common. Majority, mild to moderate, meaning not severe, they don't end up seeing a doctor. Transient, meaning it lasts very few days, in the first week, maybe a couple of days, and you are back to normal. So again, this just summarizes some of the effects and what to do. Take normal analgesia, paracetamol, some allergy medication if you think there's a bit of redness, and if you're concerned, obviously, speak to your healthcare provider. Those are the common side effects. And then there's a lot being made of the rare side effects. And I'm going to touch on them just to put them in context in terms of how rare they actually are, but also what they are. So the first one is whenever you take any medication or food or any ingredient for the first time, you do not know if you are allergic to it. Like bee stings, for example. If you are allergic to it, you might have a severe allergy, which we call anaphylaxis. But this occurs with COVID vaccines in the US, 2 to 5 cases. So let's call it 5, up to 5 cases per million doses administered. Okay, usually within the first 15 minutes, and the majority get treatment. And that's why after every dose of vaccine, you are normally observed for between 15 to 30 minutes, is to make sure that you don't have this extremely rare but treatable complication. So if you had to collapse in the doctor's rooms, they put up a drip, they treat you with adrenaline, etc., and you will recover. The second one, which has become prominent in the last few months, is what we call an inflammation of the heart, a pericarditis or a myocarditis, and it's just swelling around the heart. And this happens in about, more specifically with the mRNA, that's the Pfizer and Moderna virus vaccines, and they're usually around 5 cases, again, per million doses. So really, very rare, usually in the first few days, and the majority recover again. Limiting, some people will actually have it without even knowing that they've had it. They might feel under the weather for a week or so, a bit of tiredness, etc., and then recover. The third one is a neurological syndrome called Guillain-Barré syndrome, which can result in paralysis from the feet up. Can happen normally after any viral infection. So you can have a sore throat, and 3 weeks after that, get this type of complication. It's not unique to vaccines. Because we're trying to mimic an infection, that's probably why sometimes we can trigger this. But it happens more with the Johnson & Johnson vaccine, up to 12 cases per million doses. It happens in the first few weeks, and again, majority will recover. So there's a fourth complication that I want to put in context, and that's the blood clots, which have received a lot of attention. And I'm sure amongst the audience, there are many smokers, and there are many women using contraceptions, oral contraceptive pills. So the risk of clots with the AstraZeneca vaccine works out to approximately 4 cases in a million. For women taking contraceptive pills, that risk is a minimum of 500 per million women. So we're talking 100 times increase in the risk of blood clots caused by the vaccine versus the pill. But we don't hear anything about clotting with pills, and no one's running campaigns to stop birth control pills. Smoking, we're looking at really 1,700 cases in a million versus 4, just by smoking. That's your risk, and that's how many clots it causes. And by contrast, if we look at COVID infection on its own, can cause 165,000 cases per million. So these 3 really are your risks for blood clots. The vaccine isn't. There's a website in the United States, National Safety Council, which looks at injuries and calculates odds of dying. For example, your odds of dying in a car accident are 1 in 114, whereas in a plane crash, it's 1 in 9,821. So I said, let me do some comparisons with this and the side effects. In the United States, obviously, your risk of dying in a car accident is 9,345 out of a million. Dying while cycling, 261 out of a million. In a plane crash, if you do the numbers, it's about 100 in a million. And dying by bee or wasp stings, 17 in a million. That's your odds of getting any of these. And if you notice the numbers, all of them are higher than getting any of the rare side effects from a COVID vaccine. So dying in a car, I mean, we're not going to go into cars because we've got such a high risk of dying, but it's to put it into context. I think we overreact sometimes with some of these side effects, and they are serious. If it happens to you, please get treatment, but the risks of getting it are really insignificant when compared to the normal risks we take on a daily basis. Okay. What are your risks of dying from COVID-19? Because obviously you're going to say, no, I don't want to get vaccinated. So what are your risks of dying? If we look at the risk of dying out of a million people globally, so that's taking every country, even though the underreporting of different countries of deaths, etc., you've got a risk of 569 per million. Compare that to the risks of getting some of these extremely rare and treatable side effects or rare safety issues. So I think really in terms of safety, I'm very much at ease recommending the vaccine. This is my second last slide. I just like to go through some of the myths and facts relating to vaccines because these are regurgitated on social media platforms and they're more to sensationalize and scare people rather than inform. So the mRNA vaccine does not affect your DNA. As I mentioned, it's a coding system that goes into the body and basically tells your cell to make a certain protein. It does not alter your DNA or your code. This is an important one. The second one, if you've already had COVID-19, you don't need to get vaccinated. False. So natural infection does give you some immunity. So if you've had, for example, the Delta variant infection, it might protect you from the Delta variant, but it might not protect you, firstly, from the other variants. Secondly, it might not protect you for as long as a vaccine would. I mean, in our study, in the AstraZeneca Oxford study, we found that infection with the original virus offered zero, and I emphasize the word zero, protection against infection from the Beta variant. Really, it was shown, published. So I think, please do not think that if you've got COVID, you don't need to get vaccinated. Consult your doctor. We normally wait for about 30 days after your symptoms before we recommend the vaccine, but you should get vaccinated. The rate of survival, I think I've covered that in terms of hospitalization and death, in that really the benefits really outweigh. And secondly, by preventing the spread, we prevent the elderly and those at risk from getting infected. So we then contribute to, assisting the larger community we're in and our country and the continent and the world at large. So I think that's very important to sometimes not be focused on only yourself. Serious side effects, again, I think, no one in science is hiding any information. The research product has been through the normal steps with the same number of patients being tested, etc. Laboratory tests, all have been done. They've just been done in a condensed version. So it's just been done rapidly to address the pandemic, but no corners were cut, no steps were skipped. So we know the side effects. I've put it into context. We don't know what's in these vaccines. That's a really lazy statement by whoever makes that. I mean, every manufacturer, there's details published of the exact ingredients to the lowest amount. We're talking micromoles or nanomoles of substances that they declare. I mean, we go to and we buy sometimes, whatever it is, sweets, food. I mean, we don't even know exactly what's in those, but we want to worry about the vaccine that's been studied. And there's a bit of scaremongering in that they say vaccines will make you infertile or cause miscarriage in pregnant women. Completely false. They do not affect fertility. There's no reason or scientific basis how it could. It has been shown to be safe in pregnancy and during breastfeeding as well. And some countries have already endorsed that and started vaccinating because they are at higher risk. Pregnancy is a higher risk for complications from COVID. The vaccines were developed using human fetal tissue. Again, completely false. If you fact check a lot of this information, you'll see that someone says it somewhere and it just spreads, and no one bothers to say, is this actually genuinely true or not? I mean, the next statement is an example of that. Tracking devices in these vaccines. I mean, really, why would the government want to know where I am and when I go to the shop or to the gym? I don't understand why they would want to track me, but it's implausible scientifically. In all these studies so far that I've been involved in, the vaccine has come in a big vial with multiple doses. So how would I pick out one chip to put into one person if I'm just drawing randomly? Really, it's just, that's the level of arguments I get into with some people, but that's absolute nonsense. You do not need to wear a mask. That's something very important that you should still. Remember, we're saying that there are some people who are asymptomatic positive, meaning they don't know they have it, firstly. Secondly, as I've shown, the vaccine will prevent hospitalization and death, but it might not necessarily prevent you from getting infected and infecting others. So I think there's still a major need to wear masks in order to look after public health and to be a responsible person in society. Again, the last point saying that vaccines were rushed and unsafe. It is true that we condensed a lot of the steps. It was expedited, it was made efficient, but firstly, no steps were left out, no corners were cut. Thirdly, all the regulatory bodies, whether it's the FDA in South Africa, we have SAPRA, the African continent has the African CDC, Center for Disease Control, all of these independent organizations, doctors, scientists from those countries evaluated the data themselves and declared them to be true, to be safe. So it's not just that the company comes out and says, yeah, we've got an answer. These are independently verified, published for the world scientists to review, and then and only then are they rolled out. So I think, I might have missed a few myths or facts, but I think this gives you a pretty good overview. I hope, I've got my message across and that people, hopefully have learned that knowledge is power, and, you need to empower yourself with the knowledge, check your information. And with that, I say thank you.